Talkie session is on HRCT, part 1 by Professor Dr. Koushik Muthuraja.
Very good afternoon. I'll be talking about the basic patterns of HRCT, which everybody should know before interpreting a disease. So I might rush through the slides, but then if there is any issue at the end of the session, you can let me know. So why do we do a HRCT? What is a HRCT? It's a use of thin section of CT images, often with a high spatial frequency reconstruction algorithm to detect and characterize disease affecting the pulmonary parenchyma and the airways. It's superior to the chest radiograph and the conventional radiograph when you want a sectional, like a thin sectional anatomy of the lung parenchyma. So these are the list of interstitial lung diseases which you can diagnose using a HRCT, but this will be discussed in detail by the next speaker. So what are the HRCT thorax patterns that are most prevalent and which is most common? So the first one is reticulations, the second one is nodules, the third one is cysts, fourth one is heterogeneous attenuation, fifth one is mosaic attenuation, sixth one is airspace attenuation, seventh one is ground glass attenuation, and the eighth one is consolidation. So these are the entire gamut of patterns which is available in the HRCT. So what is a parenchyma? A parenchyma has airspace and interstitium. Okay? Okay, what does the airway has? The airway has bronchi, which has cartilage, and bronchioles, which do not have cartilages. Then the bronchioles, we have a terminal bronchiole, which does not have any air spaces attached to it, and we have a respiratory bronchiole, which have air spaces and participate in respiration. So this diagram you might see in the next 5 slides continuously. Just look into this very carefully. So this is a here you could see a hexagonal structure, which is a secondary lobule. This is a primary unit of a lung, so which you should know, because all your interstitial patterns or HRCT pattern will depend on a secondary lobule. So the secondary lobule is hexagonal in shape. It has one terminal bronchiole which is coming in, which is also called as a lobular bronchiole. Along with it, you have a pulmonary artery, and the sides of this secondary lobule, you have the pulmonary veins and the lymphatics, and they end in the pleura. So the pleura also has lymphatics. Please have that in your mind. The pleura also has lymphatics. On all the alveolar sacs, they also have lymphatics. So please remember, but there is an interstitium outside the alveolar sacs also, which you should remember. Okay, that will cause a separate pattern in your CT. So then we have the acinus. Acinus is, we'll discuss about the acinus in the next slide. So what is the acinus? Acinus is a functional unit of the lung. It's a structural and functional unit of a lung parenchyma. One respiratory bronchiole with alveolar sacs, you call them as an acinus. Okay. Then what is the secondary pulmonary lobule? We discussed about this. It's a fundamental unit of the lung, and the structure is hexagonal in shape. It reproduces the lung in miniature. Airways, pulmonary arteries, veins, lymphatics, and lung interstitium are all represented at the level of a secondary lobule. The recognition of lung abnormalities relative to the structures of the secondary lobule is a fundamental to interpretation of thin section CTs. Okay, you should know everything about secondary lobule. The anatomy of secondary lobule is very, very important for you to even diagnose what pattern and what disease it is. It measures about 1 to 2 centimeters, and it is made up of 5 to 15 pulmonary acini, average is somewhere around 9 to 10, that contain the alveoli for the gas exchange. So again, so this is the, you could see the secondary lobules here very clearly demarcated, which ends up in the visceral pleura. So coming to this diagram, here you can also see there is an pulmonary artery, the cross-section, axial cross-section, where you could see a bronchus, a pulmonary artery, and then the hexagonal shape, and you could see the interlobar septa and the alveoli represented in the blue circles. So what, coming again to the secondary lobule, the second one is actually an what do you say, it is actually an enhanced image, a thin section which has been hyperinflated lung, and then they have taken an image of it, where you can see there is a lobular bronchiole which goes in. Along with it goes the lobular artery, which is shown in the black color, and then they divide, they supply two secondary pulmonary lobules, and there is a terminal bronchiole, and you can see the respiratory bronchiole, and which goes into the acinus. The same is represented on the image on the left side as well. Sorry, right side as well. The same thing here. Why again and again I'm showing this in a multiple dimensions or multiple images? You have to know this. This is actually a line diagram behind over a HRCT. Here you could see the same thing again. So coming to the secondary pulmonary lobule, so this is the area which is called as the centrilobar area. The one in the yellow circle is the centrilobar area, and the one on the right side where you can see the multiple arrows are the perilymphatic area. Okay, so the perilymphatic area is there in the pleural surface and also in the adjacent walls of the interlobar septa. So coming to the patterns, you could see here. What are the patterns? What are the patterns that is available that you can diagnose in a HRCT? So this is the normal secondary lobule. Starting with the normal, then you have the thickened interlobar septa, which you can diagnose. Then you have the thickened intralobular septa, which I told you, the interstitium surrounding the alveoli. Okay, then we have the thickened bronchovascular core, then we have the fissural nodules. You could see the smooth fissure starting in this extreme, and there are nodules in the second half. Then you have cysts, then you have lobular opacities, which could be ground glassing or consolidation. Then we have traction bronchiectasis and honeycombing, and then we have consolidation. So these are the patterns which we are going to discuss. So what's seen on a normal HRCT, interlobular septa, possible or not, may be possible. Okay, it's not always seen. Second, pleura not visible, lymphatics not visible, pulmonary artery visible. Okay, so all the white color opacities which you see in your HRCT are basically images of your arteries or the vessels. Okay, those are not the bronchus unless until they are, if there is a pathology. So what is the secondary pulmonary nodule findings? We can have reticular finding, nodular, increased density of lung, decreased density of lung. So what are the reticular opacities? We have interlobular septal thickening. Normal septal thickening is 0.1 mm. If it is thickened, it will become somewhere around 1 to 2 mm. Then we have peribronchovascular thickening. Then we have intralobular septal thickening, which is otherwise called as non-specific reticulations. Then we have traction bronchi or bronchioles, which causing bronchiectasis or bronchiolectasis. Then we have honeycombing. So these are the patterns which we will discuss now. So this is an interlobar septal thickening, smooth interlobar septal thickening. I'm not going to discuss about where you will get it. It will be discussed in the next talk. So this is a smooth interlobar septal thickening. Okay, can you identify this? Yeah. Then we go for nodular interlobar septal thickening. Okay, smooth, then nodular. Then the third thing is irregular interlobar septal thickening. So we have three types of interlobar septal thickening: smooth, nodular, and irregular. Okay, then we have intralobular septal thickening. You could see the intralobular, which we discussed. Why does this happen? Because of thickening of the alveolar wall. Okay, the interstitium of the alveolar wall. So then we have peribronchovascular thickening. Okay, then we have peribronchovascular thickening. Along the bronchiole and the pulmonary artery, we might have thickenings. It is called peribronchovascular thickenings. Then we have honeycombing. Honeycombing, criteria to call a honeycombing: there must be variable sized cysts, it should be subpleural, there must be sharing of walls, 3 mm to 1 centimeter thick walls can be there, minimum 3 cysts should be in the row to call it as an honeycombing. Okay, then we find this in the late stage fibrosis. Then we have traction bronchi or bronchiolectasis, like identified in that image. This usually occurs because of the peribronchi or peribronchiolar fibrosis. Because of the fibrosis, there is a traction which dilates the air spaces there. Coming to the nodular pattern, when you say it is a nodule, if it is less than 3 centimeters, we call it as a mass. When it is more than 3 centimeters, if there is a nodule, then you further classify it into a micronodule, small nodule, large nodule, or miliary. Less than 3 mm is micronodule, less than 2 mm is miliary. Anything between 3 mm and 10 mm is a small nodule, and anything between 10 mm and 3 centimeter is a large nodule. So coming to the morphology of nodules, we have solid calcified pulmonary nodules, ground glass pulmonary nodules, which are partly solid or non-solid. So we have a solid nodule here, then we have a ground glassing nodule there, then we have a partly solid nodule. So coming to the other nodular pattern locations, the nodular pattern can be centrilobular, it can be perilymphatic, or it can be random. So we saw the which area is called centrilobular, which area is called perilymphatic, and we are going to see the random pattern. If it is perilymphatic, then you have to further classify them, whether it is in the interlobular septa, or it is subpleural, or it is peribronchovascular interstitium, or it is a centrilobular peribronchovascular interstitium, which is a hybrid. The last one is a hybrid. So these are the, that is the random nodules. The second one is, one in the middle is classical centrilobular nodules, and the one in the bottom shows the perilymphatic nodules and also interlobular septa nodules, and also the peribronchovascular nodules, and the one in the circle is the centrilobular peribronchovascular area. So it is very important. So coming to the centrilobular nodules, these are the examples for centrilobular nodules. This is how you will find the nodules in the CT. It will be right in middle of your secondary lobule. Okay, the nodules will be right, and it will be classical, it will be same, and there won't be any disparity among the distribution in all other secondary lobules.
5 more minutes, sir.
Coming to the perilymphatic nodules, this is the perilymphatic nodules. Along the perilymphatic areas, you could also see there is a perilymphatic nodules along the interlobular septa here. Okay, and also the nodule perilymphatic along the bronchovascular bundles, and also the subpleural perilymphatic nodules are also seen here. Coming to the random nodules, they don't follow a particular pattern. They might be few nodules will be centrilobular, few nodules will be perilymphatic. So this is called as random nodules, usually seen in a miliary pattern. Coming to a tree in bud pattern, this is very important. A tree in bud pattern happens when the bronchioles are also involved. Okay, in a centrilobular nodule, the bronchioles need not be involved, only the lobule can be involved, but in a tree in bud, the bronchioles is also involved. Okay, that is very, very important, and this is how the opacity looks like. And you could see there is a classical arrow which shows a classical tree in bud nodule in the middle image, and the one on the right extreme shows the fulminant tree in bud nodules in case of a tuberculosis. Coming to the reticular nodular pattern, this is again a hybrid pattern where you will have both nodular and reticular patterns together. Coming to the increased density of lungs and opacity, we have two conditions here. One is the consolidation and ground glassing. The major difference of consolidation and ground glassing is in consolidation you cannot see the vessels through them. In ground glassing you will be able to see the vessels through them. It is very, very important. And ground glassing suggests there is an acute inflammatory or infective process going on. So this is a classical example of a GGO where you can see the vessels through the ground glassing opacity. This is a consolidation where you could see air bronchograms, but you cannot see the vessels through the opacity. So coming to the decreased density of lungs and opacity, we have 4 things here. One is emphysematous changes, then we have cysts, then we have air trapping, then we have mosaic patterns, then the others blebs, pneumatoceles and bullas. So whenever there is a low density image, okay, 2 things you have to check, whether these patterns have a wall or what is the shape. Okay, these 2 things are very important. Walls present or absent, shape is either it is round or geographical. So this is emphysema where walls are absent commonly, very thin walls may be found, which is uncommonly, and they are not circumscribed. Okay, they are not defined. Okay, so you could see the right lung here, which is with the destruction of alveolar walls causing the emphysematous changes in bilateral lungs here. So these are the loosened opacities: cyst, cavity, bulla, bleb, and pneumotocele. You can take a picture of it, and you can read it later. So coming to the cyst, in a cyst the wall is present, it is round and oval, you are able to the lesion is circumscribed, and we have 2 kinds of cyst. One is a primary cystic lung disease, second is a cyst secondary to fibrosis, ectasia, or if there is an honeycombing. Okay, these are for the cyst, and you could see the arrow mark pointing out showing well circumscribed lesion with the walls. Coming to the blebs appear as small air spaces. Usually they are seen within the layer of visceral pleura or subpleurally. They have thin walls which is less than 1 millimeter thickness. Coming to the bulla, bulla also has a thin wall which is less than 1 millimeter and usually larger than bleps, which are the size is more than 2 centimeters. Coming to the pneumotocele, pneumotocele are rounded thin wall air spaces that represent distended air spaces distal to the check valve obstruction of a bronchus or a bronchiole. Always remember, pneumotocele is secondary to one obstruction, okay, usually secondary to one acute infection or pneumonia, okay. Coming to air trapping and mosaic perforation, very, very important. You cannot call air trapping in a inspiratory scan. To say it as an air trapping, you need an expiratory scan. Okay, usually we ask the patients to take deep breaths and hold, which is an inspiratory scan. If you want to confirm air trapping, you have to ask the patient to expire and do the expiration and then take a scan and expiration and hold. Okay, fine. So in inspiratory scan, it is a mosaic perfusion. In expiratory scan, it is a air trapping. So in air trapping, there is no walls. Here it is geographically distributed. There is the air trapping signifies airway problem. Mosaic perfusion signifies vascular problem. Okay, there is a difference. Air trapping signifies airway problem. Mosaic perfusion signifies vascular issues. So if the air trapping is in small area, it signifies a small airway obstruction. If it is in a larger area, it signifies a larger airway involvement. So this is how air trapping looks like. All those areas which is less in density or where your air trapping is there, this is an expiratory scan. Okay. Coming to mosaic perfusion, it's an inspiratory scan, usually caused due to vascular abnormalities like pulmonary artery hypertension, vasculitis, and pulmonary thromboembolism, where there is a decreased perfusion. Decreased perfusion, that is why it is called as mosaic perfusion, and that is called as air trapping. So this is an inspiratory scan showing areas of hypodensity because of less vascular perfusion to those areas. Coming to the crazy paving, it is a combination of ground glass opacities with superimposed interlobular septal thickening and intralobular septal reticular thickening. So this is how a crazy paving looks like. There is a ground glassing, there are also inter and intralobular septal thickening. Okay, this is the crazy paving, why the name it is called as crazy paving pattern. Thank you.